Hello, my name is Ernestina Edufo, registered dietitian, and the topic of my presentation is the role of nutrition and dietetics in disease management. The outline of the presentation, we'll talk about nutrition and the pathophysiology of chronic diseases, looking at the nutrient triage hypothesis and inflammation, the impact of medical nutrition therapy on various diseases, operative related stress and recovery, hospital malnutrition and cost effectiveness of medical nutrition therapy and the roles and responsibilities. So we can use the Eat Well guide to help us to have a refresher on what is food and what is nutrient, and that will help us to be able to link it with the dietary management of food for sick patients. So this plate helps us to understand the proportions of foods to eat within a day, and then helps us to plan our meals. So for a healthy diet or to maintain a healthy nutritional status, we say that people should eat foods from all the food groups. So here we have our starches and sugars. So we have carbohydrates, and we have examples: yam, cassava, cocoyam, rice, whole rice, potatoes, sweet potatoes, whole grain cereals like millet and corn and sorghum and the like. And we have processed carbohydrates like bread and bagels and the others. Then we have our vegetables. So vegetables, I can see contomere, I can see bananas, vegetables and fruit, bananas, cucumber, cabbages, aubergine. We have frozen vegetables, frozen peas and the like, dried fruits like raisins, and then mushrooms and all those things. And then for the proteins, we have beans and lentils and tuna and fish and eggs and chicken and meat and lean meat. Then we have dairy and alternatives. So we have soy milk, almond milk. For the cow milk, we could have skimmed milk. We could have 1% fat milk. For cheeses and other processed milks, we could have the low-fat versions, cottage cheese and the others, and unsweetened low-fat yogurts. Then we have oils and spreads. So oils and spreads, we're talking about seed oils like granite oil, corn oil, canola oils, and also spreads like butter and margarines. But we are saying that when it comes to fats and spreads, we need very little of them. Coconuts, usually we are worried about saturated fats when it comes to fats and spreads, but we say that the oils are usually generally very low in saturated fats, and coconut oil, which is high, and palm oils, which are high in saturated fats, have been found not to actually cause the blood cholesterol to go up. So even though they are full of saturated fats, the saturated fats in coconuts, for instance, is short-chain fatty acids, and because of that, that makes them makes it still safe, even though it's saturated fat. So we can have this, and we are saying in a day when we are eating, this is how the proportion should look like. At least a third of the plate should be the whole carbohydrates. Another third should be fruits and vegetables, and the remaining third should be the protein, the milk, and a little bit of fat. We are saying that if you look at the plate on your left side, bottom left, you have the sauces like the ketchup and cakes and crepes and biscuits. And we are saying these ones are not too healthy for us. They are high in saturated fats, fats in general, sugars, and sodium. So even though you see chocolate there, and chocolate may be one of our favorites, we are saying that it may be high in sugar and fat, so it's not as healthy as it may appear. And then we have the water. So water is another very important thing for us. We should try to drink a lot of water, at least 6 to 8 cups of water a day should be fine for us, and a cup is about 250 milliliters. So we should drink a lot of water because we need water for all the processes in our body to work, and so we should drink a lot of water in the day unless it is medically indicated otherwise. And then when we choose to buy processed foods, we should check the labels and make sure that we are buying those that are low in sugar, low in fats, low in saturated fats, low in sodium. Now we can look at the nutrition and the pathophysiology of chronic diseases. So we can look at the nutrient triage hypothesis, and this argues that Nutrients are preferentially used for processes that are critical for survival during periods of low dietary supply. This infers that some tissues may be lacking during times of insufficiency. So when there is inadequate nutrient supply, the body focuses on survival. So nutrients that are meant for other things or other body systems may not be used for those things, but will be used rather to supply energy or to do something that is critical for survival. And this can affect how the body systems work, because body systems that are deficient will show signs of deficiency and can affect their function and can lead to chronic diseases. The classical diseases of deficiency, like kwashiorkor, like rickets, these are seen at the extremes of deficiency, but between a little deficiency to the extreme, when we have inadequate intake, it affects the whole system because the use of nutrients is disturbed. Now we can look at another concept of chronic disease pathophysiology, the inflammation that is nutrient related. Is the inflammation is inflammation there? This is the complex biological response of vascular tissue to harm and stimuli. And when we have stresses on the system, stresses, toxins, autoimmune issues, antigens, trauma, infections, poor lifestyle habits such as poor food intake, inadequate intake, or excessive intake, smoke, nicotine abuse, alcohol, excessive alcohol intake. All these results, excessive sugar intake, result in total, but also high levels of inflammation, especially chronic inflammation, has also been linked to chronic diseases. Several studies have shown that persistent inflammation is a key factor in the development of chronic illnesses. Maternal inflammation programs the fetus for a life of chronic disease, and this is because if the mother has high inflammation load, the fetus will also have high inflammation load, and it has been shown that fetuses like that grow up to exhibit chronic disease in their adulthood. Inflammatory biomarkers such as C-reactive protein, sedimentation rate, interleukin-6, and the others have been linked to inflammation and these chronic diseases such as cancer, diabetes, autoimmune diseases, Alzheimer's, arthritis, neurological diseases, cardiovascular diseases. So this shows that inflammation directly is linked to non-communicable diseases, and healthy eating can reduce inflammation. So that's why nutrition is important in sick people. A diet that is high in plant foods, high in antioxidants, phytochemicals, and flavonoids, vitamin B, vitamin C, vitamin D, have been found to lower oxidative stress and inflammation. Medical intervention itself is the use of evidence-based nutrition to manage disease conditions. And the primary goal of intervening is to prevent or delay the progression as well as manage the disease. Some illnesses that have been linked to dietary intake, we have overweight and obesity, cardiovascular diseases, diabetes mellitus, kidney disease, cancer, osteoporosis, and gastro diseases, to mention a few. Are linked to diet, and medical nutrition therapy can be used to manage them. Okay, because the emphasis of this presentation is on anesthesia, I want to stress more on surgical response and the diets, how we can use diet to manage. So we said that with surgical stress response, the nutritionally relevant clinical consequence of surgical stress response is hyperglycemia and catabolism. With hyperglycemia, we are looking at peripheral or central insulin resistance. And then with catabolism, it's manifested clinically as the wasting of lean muscle tissue and including muscle, the lean tissue, including muscle, and largely occurs due to reprioritization. So if for the hyperglycemia, usually the diet plan, like I mentioned for weight management, will do. In addition, with the carbohydrates, we are looking at carbohydrates that have low GI and reduce carbohydrate portions to just enough, and that calculation can be done with the help of a dietitian to do that. So just enough, and then increase the vegetable intake, encourage beans and nuts intake, and also physical activity. With the catabolism, we say that what I explained about the nutrient triad hypothesis. So in times of surgery, lean mass is mobilized, releasing amino acids into circulation for the preferential uptake by the liver to allow the synthesis of acute phase reactants and the production of glucose from non-carbohydrate sources via gluconeogenesis. So when there's increased stress level post-surgery, there's increased inflammation, there's increased need for healing, the body needs a lot of energy. The body would prefer to use protein, lean mass, if there's inadequate energy intake and there's inadequate protein intake. The body will rely on lean mass to produce energy for survival. So that is what will cause increased catabolism that will lead to muscle wasting, and that's will lead to poor outcome. So to prevent this, there should be pre-operative energy reserve. So before people are put to surgery, unless it's emergency surgeries, their nutritional status should be assessed and patients should be put on a proper meal plan to get them to be healthy before they do the surgery. Otherwise, physiological integrity and strength will be compromised. Now we can talk about malnutrition in the hospital. So malnutrition relating to surgical patients, we say that it's an unbalanced nutritional state in which the nutrient intake does not match nutrient needs due to underlying diseases. So the person may already come with comorbidities before the surgery due to surgical stress response, due to chronic or acute inflammation, due to intestinal malabsorption. So other things that come up like diarrhea or vomiting post-op from anesthesia, side effects and all that. And patient-related factors. So some people become anorexic in the hospital. They hospital-induced anorexia. They lose their appetite, and sometimes the economic status. So a lot of money has gone into the surgery, and they may not have enough money if they don't have insurance to provide adequate food to meet their needs, and that can lead to losses in lean tissue and then diminished function. International studies have reported rates of malnutrition in hospital patients at about 40% and in surgical patients about 50%. A study was done involving 3 hospitals in Kenya and Ghana in 2019 by Blau et al. And they found out that about 62% of patients on admission in this hospital were malnourished, were at risk of malnutrition, And then about 71% of the patients upon discharge were also at risk of malnutrition. So it tells us that malnutrition is real in our hospitals. And if we don't take care of the nutritional needs of our patients, we may end up sending them out only to have them come back in a poor state or pass on. How does malnutrition develop? So taking a person who even has optimal nutrition status, when they get ill due to stresses from other sources or inflammation from stress and other things, toxins and all that can happen. When they get ill, metabolic abnormalities happen, which is associated with the disease or the treatment. That may increase the need for nutrients and other things. They may have gastrointestinal abnormalities like malabsorption, like diarrhea, like vomiting, that can affect nutrient intake and also affect nutrient absorption. Then there could be mechanical obstruction. They could have tumors, they could have polyps that can be affecting their intake, and there could be drug or nutrient-related side effects. So sometimes the medication they are taking could interfere with certain nutrients they need, and because of that, they are not having these nutrients in there as much as they need. Then there could also be patient-related factors, so poor appetite and socioeconomic factors, inadequate sufficient food sources or income to provide adequate food. So by the time the patient is on admission, their nutritional status could have dropped from optimal to about half. And on admission, there could be more metabolic abnormalities associated with surgical stress response. There could be gastrointestinal abnormalities, more diarrhea, vomiting, and other things. There could be organizational and food access barriers in the hospital. So sometimes the issue is the hospital. Sometimes the food provided is not wholesome. Sometimes the food provided may be, but people have a perception that hospital food is not good, and they may not be eating it. They may be relying on food from home, and their caregivers don't really know how to prepare wholesome food for them or have not been educated. So they do not provide, and then that affects their nutritional status. And sometimes it's just pure knowledge deficit. Nobody has told them what to do. They are sick, they get confused, they start to eat anyhow, and it affects their health. And so the nutritional status from optimal may be close to almost very little by the time they are being discharged to go home. And what are some of the clinical effects of malnutrition? We have, there could be ventilation. For ventilation, there could be loss of muscle and hypoxia responses because they don't have enough muscle. Even breathing, respiration becomes an issue. It could affect their liver. There can be decline in renal function, liver function. It could affect wound healing. So the surgical patient may stay longer in the hospital because the wound is not healing well. And remember, there could be hyperglycemia happening. That can, all these things go around to impede on wound healing. And then also it can affect the gut. So malnutrition can make the malabsorption worse or gut integrity even worse, and that can affect their total overall intake as well. Then loss of strength, cardiac output, and immunity. So they will be at risk of more infections that can let them stay longer in the hospital. And this all goes to increase the cost of treatment because hospital stay increases, more medication needed to treat opportunistic infections, and this can increase mortality. So we can see that nutritional deficiencies and depletion have an impact on surgical recovery, and it's very important that patient nutrition is taken seriously. What can be done to avoid malnutrition? There should be nutritional management pre-operation, and then during hospitalization and post this operation and then discharge. To improve nutritional status and prepare for the metabolic needs of surgery, patients should be assessed, and this can enhance wound healing, improve immunological response, and assist in functional recovery. At risk patients require individualized treatment plans, and this may include therapeutic diets, fortified foods, high energy, high protein foods, oral nutrition supplements, enteral nutrition, or parenteral nutrition where indicated. And what about roles and responsibilities? So the nutritional status and prevention of malnutrition in the hospital is everybody's responsibility. On admission or at the OPDs, it should not just be BMI that is checked or just the weight that is checked. At the OPDs or on admission, patients should be assessed for risk of malnutrition, and the patient should be monitored appropriately. And we'll see a slide, the next slide will tell us more about that. In the hospital, there should be provision of wholesome food, and there should be monitoring and evaluation of the food produced so that we ensure that the food provided is always wholesome. And where they have this policy where during meal times and other nursing care activities apart from emergencies are halted so that nurses can dedicate time to ensuring that patients who can feed themselves are eating, patients who need assisted feeding are being assisted so that everybody's meal is protected, and medication time and food time is not compromised for medication or other cleaning or other processes. Then we can talk about education on discharge. So usually when patients are on admission, they may not be able to take medical nutrition therapy advice. So ideally, when they are better and ready to go home, that's when the discharge education should include food intake, and patients at risk or patients who have signs of malnutrition should be referred to nutrition and dietetic professionals for further management. This is an example of a nutrition assessment tool. So it comes in various steps, and scores are given. And the score a patient gets will tell you whether they need more help or they are okay but need monitoring. So the first step, the BMI is measured, and if patient's BMI is greater than 20, this or they are obese, they score 0. If their BMI is between 18.5 and 20, they score 1. If their BMI is 18.5 or less, they score 2. Now, then we add step 2. The step 2 is you have to find out from the patient, even when their BMI appears okay, they may have lost weight before coming to see the doctor. So we have to find out, have they lost more than 5% of their weight? They score less than 0. Have they lost 5 to 10% of their weight before presenting? They score 1. Have they lost greater than 10%? They score 2. Now we have to find the acute disease the patient is suffering from. If the patient is acutely ill and there has been or is likely to be no nutritional intake for 5 days or more, they score 2. So you add this step 1, step 2, step 3, you get a score. And if the score, the overall score is 0, the patient has low risk. If the overall score is 1, the patient has medium risk. If the overall score is 2 or more, the person has high risk. So if the person, from these scores, then the person can be referred for management when needed. People with low risk, they don't need, usually need referral. They can continue with the regular food intake the hospital is providing. There should be repeated screening in the hospital for like weekly to make sure that they are not dropping as their nutritional status not dropping as they're on admission. If they have medium risk, it has to be documented, and then documented dietary intake for 3 days. So we have to really take the diet history. And then if it's adequate and little concern, you can be monitoring weekly. But if it's inadequate, then clinical concern should be to follow lay down rules. So nutritional intake should be monitored, and then we have to review a care plan to include nutritional education. If the person scores 2 or more, they are high risk of malnutrition and should be referred to a dietitian or the nutritional support team, and then should be monitored weekly, and then be provided an individualized meal plan and all that. Okay, so these are my references. Thank you. If you have any questions, I'll be happy to respond. Thank you.